everybody. You are listening to the Medea podcast series. Medea, Medical Education Academy, is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today we will be speaking with Sandro Loche, senior researcher at the Bambino Gesu Children's Hospital in Rome. At the end of this podcast, learners should be able to evaluate the role of AI and other technological advances in enhancing clinical care of patients with short stature, as well as appreciate that digital technology can improve patient adherence to recombinant human growth hormone. This podcast is part of the continuing medical education programme entitled Digital Decision Making in the Management of Growth Disorders 2026, targeting clinicians, particularly paediatricians, working in growth disorder management and those in general practice. Some content may be of interest also to specialist growth disorder nurses.
Good morning. My name is Sandro Loche. I am a pediatric endocrinologist. I currently work at the Bambino Gesu Hospital in Rome, and I am the former head of the pediatric endocrinology unit at the Microsistemico Hospital in Cagliari.
What do you think are the current unmet needs of patients with growth hormone deficiency?
Oh, thank you. This is a good question. Well, as a matter of fact, patients with short stature are very frequently seen by pediatric endocrinologists. The short stature is one of the most frequent conditions for referral to pediatric endocrinologists. However, only a few of them have an endocrine cause for their shortness. And the differential diagnosis of attenuated growth is really broad. It includes hormone and non-hormonal causes. A correct diagnosis is of paramount importance in order to decide the appropriate therapeutic approach and monitor responses. How do we define a response to a normal, subnormal response to growth hormone treatment is still open to interpretation. But certainly the underlying diagnosis makes a big difference in response. I mean, for instance, patients with growth hormone deficiency have a much better growth response during the first year of treatment than patients with non-growth hormone deficiency conditions like Turner syndrome or patient with idiopathic short stature. So knowing exactly the underlying cause of short stature is very important in order to decide treatment and to decide whether the response to treatment is good or not. Another point, coming back to the diagnosis, it's good to point out that more than 80% of patients with growth hormone deficiency have idiopathic growth hormone deficiency, though there is no evident cause for the deficiency, and it may be difficult to distinguish between constitutional delay of growth in puberty and isolated growth hormone deficiency. And this is another crucial point. I mean, the vast majority of these patients, actually, they have false positive responses to growth hormone stimulation testing and show normal responses when retested at the end of growth. In other words, growth hormone deficiency does not persist beyond puberty. And it's still a matter of debate whether they have a transient form of growth hormone deficiency, or they are just false positive responses, and the problem relies with the poor accuracy of stimulation testing. And in fact, cutoffs for growth hormone deficiency, although we've been using them for decades, are still open to interpretation. Another crucial point is the rate referral and the initiation of growth hormone therapy. Why it is an issue? Because there are several data that show that the earlier treatment is initiated, the better is the long-term outcome. In other words, we need to make a diagnosis as early as possible, start treatment as early as possible to obtain the better results from treatment. Another still open issue is the great number of patients that are not fully adherent to therapy. Why this is an issue? Because it has been shown that poor adherence is correlated to poor growth. And if a patient does not grow properly, especially in the first years of life, the best results are not obtained because the final outcomes is highly correlated with the response to the first and second year of treatment. So adherence, it's crucial, especially in this period of life and this time of treatment. Another point is adherence in the transition age. There's been a recent publication showing that more than one-third of patients with permanent growth hormone deficiency in the transition age have subnormal adherence to treatment. And this is somewhat linked to an unfavorable metabolic profile. So adherence should be closely monitored in a patient taking growth hormone deficiency, and all causes of poor adherence should be addressed properly.
How can digital technology help patients with GH deficiency?
Well, I think that digital technology can be of great help in several areas of growth hormone deficiency. Digital technologies, for instance, can help monitoring responses. With digital technologies, it can be designed methods to predict the growth hormone response to any single patient, and the monitoring responses by the use of digital technology will help the physician to obtain timely results of the patient treatment and help the physician to intervene immediately to solve any problem that may be interfering with normal responses. And digital technology can also be of great help in monitoring adherence and also in addressing adherence issues. And there are several published data showing that with the use of injection devices that can transmit the number and timing of injection to a platform, the physicians and caregiver can have a real-time picture of adherence and can take appropriate measure in order to address any adherence issues for the patients.
How can digital technology help to address adherence issues?
I just mentioned before that we now have injection devices that record the number of injections and record the time of injection and can transmit these data to a platform. This technology helped to design a patient-centered digital ecosystem which collect all data from the patient, and these data can be used by the physician, can be used by caregivers, can be used by scientists to gain data to design research protocols. So the technology, the modern technology, is of great help in monitoring adherence, but also the identification of adherence-related issues by digital technology is very important, because identifying adherence issue, let me just give you an example. With the digital technologies, you can observe whether a patient is taking his or her injection always at the same time. And this is important because patients who take injections roughly at the same times are the more adherent, whereas the patients that do not follow consistency in the timing of injection are the less adherent. So using the digital technology, you may observe some of the adherence issues that can eventually be addressed by the physician itself or by the nurses or by the caregivers. Now, the problem of adherence is actually not only related to the patient itself, but it can be related to the doctor, can be related to the device, can be related to the drug itself. I mean, there are a number of factors that may have an impact on adherence. So the intervention may be directed to the patient itself, but may also be directed to the family and to the caregivers. And it is especially true when dealing with young children.
Will AI eventually take over diagnosis and treatment of children of small stature?
My personal feeling is that artificial intelligence is very unlikely to take over diagnosis and treatment of children with short stature. But it may become a key decision support tool in this field for a number of reasons. Let me just explain you what I mean. Artificial intelligence is very good at integrating large data sets like growth curves, lab results, genetics, and imagings, and in detecting subtle patterns across populations. It is also very good in predicting probabilities. Just for example, the likelihood of true growth hormone deficiency versus constitutional delay of growth and puberty. So in practice, AI could be useful to improve early detection of an abnormal growth trajectory or to reduce false positives in growth hormone stimulation testing by combining multiple variables, or support personalized dosing and monitor adherence. However, diagnosis in pediatric endocrinology is not all data-driven, since it involves the clinical context and the personal judgment of the physician, and the evolving physiology over time, and when to treat, how aggressively, and cost-benefit consideration. And last but not least, communication with families and shared decision-making cannot be taken over by AI. AI doesn't carry any responsibility, and it does not negotiate uncertainty to its parents. AI can be seen just as a tool for the doctors. There are also some practical issues. AI models depend on training data that already reflects current diagnosis ambiguity. For instance, like variable growth hormone cutoffs and the problem of false positives as false negative results. That means that AI may inherit those inconsistencies rather than solve them outright. So I personally think that AI will certainly be of great help, but clinical decision will remain in doctor's hands.
What take-home messages do we have at the end of this podcast?
Let me just tell you that probably the most important take-home message is that doctors should be aware that digital technology is nowadays a useful tool in many instances, and they should become familiar with the use of digital technologies and use it properly. The other message is more pertinent to growth hormone deficiency, and is a message of warning. Doctors should always be suspicious when a child does not grow properly. Normal growth usually is a reflection of a good health, and subnormal growth can be the first symptoms of something that is not going well in the child's general health. So, big warning: anytime doctors see a child who's not growing properly, just give an alert. This is an alert. And I think that the last message is on artificial intelligence. Don't be afraid of artificial intelligence, but use it as long as it provides a good aid also in the daily work. Thank you so much.
Thank you for listening to this mid-year podcast. For more information about our continuing medical education programs, please visit our website at midyearacademy.com.